Well, welcome everybody. Good afternoon. I'm Jessica Cothran. I'm the marketing manager for orthopedic health and sports medicine here at UW Medicine. Thank you for joining us today. Our speakers are going to talk about preventing shoulder injuries in spring sports. We are recording this webinar and we'll post it to YouTube and share out a link in a few days via email so that you can watch this again or share it with others if you'd like. We got lots of great questions from folks when they registered. So our presenters are going to cover a lot of them in their presentation and some right afterwards, but you're welcome to ask some questions on your own here during the presentation via the Q&A button that's at the bottom of your screen. And if there's time at the end of the presentation, our presenters will get to that as best they can. We have Christian Peterson with us. He's an orthopedic surgeon here at UW Medicine, and Christopher Glatz, a certified manual physical therapist. So I will hand over the presentation to both of them and I'll hop off the screen.
Thank you, Jessica.
All right. Yes. Thank you, Jessica. Hi, my name is Chris Peterson, and just a little background on myself. I'm a graduate of Bishop Blanchett High School here in Seattle. I later attended University of Montana, received my medical degree from Kirksville College of Osteopathic Medicine and residency in Ohio, followed by a sports medicine fellowship in Phoenix, Arizona at the Institute for Bone and Joint Disorders. I then returned back to the Seattle area, and I've been practicing at the sports medicine clinic for the last 22 years.
Good afternoon. I'm Chris Glatz, and I am the clinic supervisor at Advanced Manual Therapy in Ballard. I graduated from the University of Missouri in 1995 and moved out to Seattle in 2004 and started working with the sports medicine clinic at that time. I'm a graduate of the Ola Grimsby Institute residency and fellowship programs, and I am a fellow with the American Academy of Orthopedic Manual Physical Therapists. And I've been practicing in orthopedics and sports medicine since.
So as Jessica stated, we're going to review some prevention of injuries in the shoulder joint, as well as review some common problems in the shoulder joint. We'll talk a little bit about injuries to the tendons, which are normally considered injuries to the rotator cuff. We won't spend a lot of time on arthritis or injuries to the cartilage. However, we will talk about instability or dislocations in the shoulder and injuries to the ligaments, and as well as adhesive capsulitis or frozen shoulder prevention and treatment. And we'll speak a little about fractures if time allows.
Okay, so let's talk a little bit about evaluation with the physical therapist. So a common question is, can I get a shoulder injury to heal on my own? Yes, you can, certainly. But of course, you'll have more guidance if you seek the help of a physical therapist. And another question could be, what should I expect when I see a physical therapist? So when we talk about prevention, this would be ideally anytime you feel the need to work on developing more strength, range of motion, stability of the shoulder, or you begin to feel some vulnerability that you want addressed. And what you need to do is either contact a physical therapist and set up an appointment, or try to find some things that you can work on online. We're going to try and help you with that today. For recovery, it depends on if the injury is post-injury or post-surgery. You can self-refer to a physical therapy clinic if you like, or you can see a physician first, whichever makes you more comfortable. And then when to start is usually after your first post-op visit when it's a surgical intervention. You would meet with the physical therapist to establish your care plan and review your protocol, basically the directions that your surgeon has forwarded to the physical therapist to ensure that your rehabilitation proceeds along a predicted path. And you would also discuss with the therapist your goals, and you could estimate a recovery timeframe. Some things to consider would be, first, to try and keep your expectations realistic. Your injury and recovery is individual, like you, and will likely differ from others you know. I frequently hear people talk about, well, so-and-so had this problem, it's like mine. Is my recovery going to go in the same time frame, or will my intervention turn out the same way? Well, try not to get too caught up with that. Also, be patient with the process. It's likely that you'll have some really good days as you recover and a few bad days, but that doesn't mean you're not progressing as you should. And as long as the overall trajectory is in a positive direction, you're doing well. I would advise you to listen to your therapist and your surgeon. The compliance is key. You need to avoid overexertion and obey the lifting limits restrictions that are advised, or you could be sorry. You certainly do not want to cause yourself more problems as you're trying to recover.
So when we talk about the shoulder joint, it's actually a very complex joint with multiple layers involved. And as you can see on the picture to the right, you have multiple layers of muscles. Joint, actually, the shoulder itself is a ball and socket joint held together by the ligaments and the muscles of the shoulder. So I think of the shoulder as kind of layers of the shoulder, the first being the bones. So the shoulder itself is made up of 3 bones: the humerus, the scapula, and the clavicle. The true shoulder joint then is the ball and socket that we'll commonly talk about today. And the ball and socket is the humerus, and the scapula, or the part of the scapula we would call the glenoid. And that's the true joint. So when you speak of a dislocation of the shoulder, you speak of the glenohumeral joint or the ball and socket dislocating. The other joint that's involved in the shoulder is the acromion and clavicular joint, or AC joint. That's most commonly referred to when you separate the AC joint. So that's a shoulder separation as opposed to a shoulder dislocation. So the first condition we're going to talk about will be frozen shoulder or adhesive capsulitis. I like to think of it as overall stiffness in the shoulder. And it's what frozen shoulder is. It's actually a very complex situation, and we're not totally sure exactly what causes the cascade of inflammation in the shoulder that reduces the range of motion. But think of the capsule as like shrink wrap on your shoulder. And after a very simple irritant or an injury, that shrink wrap contracts, and now you have a lack of motion in your shoulder. And anybody can actually get frozen shoulder. It's most common in females aged 40 to 50, but anyone can get it. It's associated with a couple other certain medical conditions such as diabetes and thyroid disease. And normally, as far as diagnosing goes, it's pretty straightforward. Most patients will come in complaining of lack of motion, and the lack of motion is rotation, and specifically internal rotation. So for the female patient, they'll complain that they can't get their arm back to the bra strap. For the male patient, can't get their arm back to get their wallet out of their back pocket. So treatment is often very frustrating. The most important line on this slide is patience. Adhesive capsulitis normally resolves. However, it normally takes about 18 months for it to resolve. So we like to think of it as more of a freezing stage and then maybe a thawing stage, but overall about 18 months of overall treatment with a variety of methods. Anti-inflammatories are the most common, occasionally injections, but the mainstay of treatment will be physical therapy.
Okay, so when you have restricted shoulder range of motion, whether it's from an adhesive capsulitis or an injury or a post-surgery, early on in your rehabilitation process, you're going to be working on regaining range of motion. And this would consist of usually some passive or self range of motion activities. And passive range of motion is likely to start when you're post-surgery. One common exercise is something called the Codman's exercise, where you lean forward and let your shoulder swing and rotate, which is helpful sometimes post-surgery, and it's designed to promote some relaxation and some pain relief and increase range of motion. To move on from that, when you're looking to gain more range of motion, some early range of motion that we would do would be some of these more self range of motion, or what we would call active assisted range of motion. And this can take the form of a cane or a golf club, or one of the overdoor pulleys that you see in the illustration below. Your goal is to seek to increase your range of motion and not your pain. You want to feel like you have increased your range, but not made yourself so sore that you don't want to continue doing some more range of motion activities later in the day. It's best to do your exercises for range of motion several times a day for shorter sessions versus just once per day. Other activities that you might do could be some stretching. Dr. Peterson talked a little bit about some capsular restrictions, and these will limit your range of motion. When he talked about the internal rotation range of motion limitation, that's the posterior capsule that's restricted. And a sleeper stretch, what you'll see in the upper right photograph, is the individual laying on their side and pressing their arm towards the table. And the goal is not to touch your arm to the table, but to get it towards the table so that you stretch out that capsule. The photograph to the upper left is a cross-body stretch that also addresses that same area. Some other stretches could be a pectoralis stretch, what you'll see in the lower left corner. And the pecs can help produce a forward shoulder posture, which can predispose you to problems such as impingement and even some rotator cuff irritation. So that's a worthwhile stretch to perform. And then some other stretches may also be prescribed, such as some triceps and latissimus dorsi stretches.
So with the frozen shoulder, you know, prevention is the key, and really with the shoulder, preventing most injuries in the shoulder, it's for me, it's really about obtaining full range of motion. And so there were multiple questions about, you know, what is the single, and then fill in the blank, exercise, stretch, or whatever for prevention. And it's really, that's a tough one. I think Chris will try to address that a little bit later on, but really I can't emphasize enough, a tight shoulder is not a happy shoulder. So range of motion, and that's why we put it up here at number one, is really key for me. So some of the questions, so thank you for everyone sending in the questions ahead of time. We were able to place some of them in the talk. What is the likelihood of frozen shoulder multiple times? And that can happen. It's not uncommon for a patient to come in with adhesive capsulitis or frozen shoulder on the right side, and they're able to get through it, and then we'll see them 6 months, a year later, and now it has occurred on the left side. And it can also ping pong back the other way as well, and go back to the right shoulder. Now, more often than not, there's an associated condition such as diabetes or thyroid disease in this type of scenario, but it definitely can happen. So this is the important the importance of physical therapy, obtaining as close to full range of motion as possible, because as life happens, and as birthdays happen, you're going to get a little tighter. So key, obtaining range of motion through physical therapy to help prevent multiple episodes of adhesive capsulitis.
So another question would be, when warming up, is it better not to push for more stretch or to try to extend the range of motion? When you're warming up, it's a good opportunity to try and improve some flexibility, but I think the question is good because you shouldn't try to push too much and cause any kind of discomfort, because what that does is that causes a neurological guarding condition of the muscles around that joint system. And that's really gonna undermine your efforts to improve your mobility and flexibility. Probably better to do more extensive stretching in the cool down portion of your exercise program or after your activity. And what are some good warm up and cool down movements / stretching for shoulders? Some good warm up and cool down movements would be anything that gets the involved muscle groups working at a lower level to start generating some blood flow and to warm up the tissue so it tolerates tension better. If you go to a baseball game and you watch the pitchers warming up in the bullpen, you'll see them using elastic bands to do some rotation exercises to warm up their rotator cuff. And then when they start, quote unquote, warming up, they'll start with a light toss and progressively increase the force and velocity at which they're throwing. And that's a similar approach that I think you should take if you're, say, a tennis player and you're worried about your shoulder performing your serve. Perform the motion gently, slowly, with increasing speed, and you could apply the same thing to a golf swing. In general, there isn't necessarily a specific exercise, but you should try to emulate what you're getting ready to do, I think is the best approach.
Okay, so moving on from range of motion to more strength, rotator cuff problems, and a little anatomy on the rotator cuff. The rotator cuff itself is a series of 4 muscle groups. Now the 4 muscles come together and form a single cuff, and that's important to remember because it's really a single entity that tears. It may occur in multiple spots or in multiple layers, partial tears and things of that nature, but it's really the cuff together normally tears as a unit. The function of the rotator cuff historically, and once again, as Chris was talking about, you know, the pitcher, historically we all heard of the pitcher tearing the rotator cuff, and it was thought to be more of a angular force provider, but actually the rotator cuff actually sucks the ball into the socket. So think of it more as a stabilizer of the joint. So what can go wrong in the rotator cuff? Well, certainly tendonitis. Historically, you've heard of tendonitis in the shoulder. It's somewhat been renamed as tendinosis now. So in some of your reports that you're able to get through my chart or other means, you'll see the radiologists discuss tendinosis, and really that's the new term for a tendonitis or an irritation or something's going on in that tendon. You certainly can have tearing of the tendon or ripping of the tendon, and that can occur in 3 locations, either at the muscle tendon junction, within the tendon itself, or at the tendon bone attachment. Historically, when we think about how do rotator cuffs tear, we think of traumatic lesions like, and it certainly occurs traumatically, like starting the lawnmower, especially we're coming out, I'm not sure if that's a spring sport or not, but when you pull the cord for the first time, it's not going to flow very smoothly. And if it catches, then you feel a pop in your shoulder. The likelihood is that you just tore your rotator cuff. That's a traumatic tear. However, also the tendon itself ages as we age as well. And so as the tendon ages, one can just, the tendon can just fail, and you can develop more of a rotator cuff that is non-traumatic in nature. So the symptoms are normally in the rotator cuff after a traumatic event will be difficulty with motion, specifically any type of active elevation of the shoulder. And as far as how do I figure out if I have a rotator cuff tear, normally that'll be through the history, as well as a quick physical examination that either a physical therapist or a physician can perform. Now, once you're at the physician's office, there may be additional imaging that is requested. The image on the right is an X-ray, and oftentimes patients are hesitant to obtain X-rays, and I would say as an orthopedic surgeon, we gain a lot of knowledge from X-rays. It's a very straightforward way to rule out arthritis in the shoulder, as well as other conditions. The arrow on the right is pointing to a small area of calcification within the tendon, or what we refer to as calcific tendonitis. The image on the left is a MRI of a shoulder. The white inside is the dye. Oftentimes MRIs are ordered with dye or gadolinium injected into the shoulder, and this really helps us to discern whether or not there is a tear or a small tear in the rotator cuff. It's not mandatory that dye is used, but it's oftentimes very helpful, and when it leaks out, it's pretty straightforward that there is a tear. And the MRI on the right with the right arrow now shows where the dye has leaked from inside of the shoulder to the outside of the shoulder. And the white area is actually the actual tear. So where the tendon should attach at the footprint, it's now pulled back, retracted, and the white area, the voided area, is actually the tear. So some of the treatments that we utilize: activity modifications, anti-inflammatories, and Chris will speak about the physical therapy.
Okay. So as far as prevention, you would want to do exercises to increase the strength and endurance of your rotator cuff muscles. If it's post-surgery, it would be after range of motion is restored. But also if post-injury you have some restriction in range of motion, you would be advised to try and increase your range of motion before any kind of comprehensive strengthening program. If your range of motion is fine, then you can begin with strengthening exercises. Post-surgery, you may start with very light resistance and possibly even isometrics. You may also use free weights or elastic bands or pulleys. Sometimes you can do some of these exercises at your local gym with their equipment. And I also want to emphasize that it's very important to avoid pain and improper movement patterns while we're performing these exercises, so that you don't cause lack of coordination and increase the likelihood that you might have some biomechanical problems and resulting irritation and injury. A little note about the rotator cuff muscles. The internal rotation exercise is pulling the band inward towards your chest, but external rotation is rotating the band away. And it's important to pay attention to this because the muscle that produces this motion, the infraspinatus, is smaller and weaker, and it can be overloaded if you're not careful. So when using a band, be judicious about how much force you put through it. If that feels like it's too much, you can certainly do the exercise on the right, which is a sideline external rotation with a small weight, which may be more tolerable. I also want to make a note of the exercise on the left. There's a small dark arrow going at a slight incline up. One of the training errors that I see with people doing this exercise is that when they rotate their arm outward, they start extending their elbow. And when that happens, you're no longer training external rotation, you're training elbow extension or your triceps. If you rotate your arm up and out slightly, you will more directly train the external rotators.
Okay, what are some other non-operative management of rotator cuff disease that you can undergo? We spoke about the activity modification, anti-inflammatories, physical therapy. What is the role of injections? Well, historically, steroid injections have been kind of the go-to over many years, or sometimes they're called cortisone injections. However, judicious use is really where we're at right now. I think if surgery is just not an option, this can be considered. However, we now know that with injections of steroid, if for some reason you are required to have any type of surgical intervention, the outcome may be affected. And so we want to really kind of think ahead on that before just giving steroid injections. More recently, PRP and stem cell injections have become popular. And the most important thing to remember about either PRP or stem cell is on the MRI to the right, it shows where there's a defect. So structurally, the rotator cuff is not intact at that level. So the injections don't help to structurally heal, so to speak, the rotator cuff. It may help with inflammation or pain, which is our ultimate goal, but we're really asking a lot to think that that cell is going to reattach that tendon. So if there's a structural defect, or if there's mechanical symptoms, locking or catching, oftentimes PRP and stem cells won't work in that scenario. However, they are showing promise, and I'm definitely not against a trial run. So when is surgery appropriate? We talked about acute injuries, starting the lawnmower with weakness, and then after failure of conservative measures, physical therapy, anti-inflammatories, and the like. And so there's a variety of different types of surgeries, either open arthroscopic or fully arthroscopic. And the pictures on the right, the top picture then is the picture of the rotator cuff, which is pulled away from the bone. And then that rotator cuff is captured with suture, which you can see it looks like the little string going now into the tendon. And then it disappears into a little hole in the bone there. And that's an anchor that we have securing the suture to that bone. It's tightened, and then the tendon itself is attached to the bone.
Okay, so what to do for your rotator cuff post-op? Initially, for the first 6 weeks, there would be no active range of motion or lifting, and that's to preserve the repaired tissues. Once that time frame has elapsed, you can begin some gentle strengthening exercises. You would certainly want to follow your surgeon's protocol. And again, we put a premium on regaining range of motion. And once that is achieved, then your strengthening program will follow. And we already discussed some of the rotator cuff strengthening exercises. So we'll move on to a Q&A for the rotator cuff.
So rotator cuff, how to heal a rotator cuff injury and avoid surgery. And I think Chris kind of hit it with, range of motion is very key, not only to prevent, but also during your recovery of your injury. The rotator cuff itself, if there's a structural defect, will never structurally repair without surgical intervention. So you can so-called heal a rotator cuff without surgery. However, structurally, the rotator cuff won't be intact, but that's normally through gaining your range of motion back and then recruiting the other muscles, because the tendon normally falls back to a stable rim. And then if we can get the other muscles to participate in stabilization, then you may be able to be asymptomatic and perform all the activities that you would like to do. Prognosis of a partial thickness supraspinatus tear, it's actually good. Normally the partial thickness tears, I think of them as more wearing as opposed to an actual tear. The word tear, it seems like it's pulled away from the bone if you say tear, and if you use the word wear, it kind of sounds more like thinning. So everything is intact in the shoulder, so there's nothing really surgically to go in and repair. It's just thinner. And so once again, obtaining range of motion and strengthening the muscle around it, very important. This is where maybe the stem cell and the PRP would be most beneficial. And then, Chris, I have some other rotator cuff questions that aren't on this chart. I'll just add here. What is the most commonly torn tendon? Supraspinatus is the most commonly torn tendon. What is the recovery? Okay, good, you've got them up. Okay. Are the other ones coming up? There we go. Maybe you can address the other two.
What is the recovery time after surgery for a rotator cuff and labrum? On average, about 6 months is what you should expect. That does not mean that it will be 6 months before you're using your shoulder again. You will, spend your 6 weeks before doing anything significant as far as strengthening. But as soon as you can start that process, you will start regaining some function and you will be able to use it for light activities. You will be showering, you will be dressing, you will be eating, you can do some light, obviously some light office work, that sort of thing. And then as the weeks and months progress, it should get better and better, and you should have more motion, more strength, and more ability. But before you can say, when am I actually done? 6 months would be average, I would think. And then the last question is a great one. I thought my issue was from my playing tennis. Then I switched from sleeping on my side to my back, and now the pain seems to be gone. Well, at first glance, you might think that while you were sleeping on your shoulder and you were irritating your shoulder. But the other issue might be that you slept in a position that did something to your neck and you irritated your cervical spine, possibly some of the nerves in your neck, and that caused some dysfunction in your shoulder. So that could be why changing the posture and sleeping seemed to help this particular case. Sometimes your shoulder pain is driven by your neck, and it can commonly be seen in people that work more sedentary occupations, the software coders, the quote unquote desk jockeys. So that is something that we would certainly look at in your physical therapy appointment if you were to say that I had no specific injury, but I have this pain in my arm, and that radiates from my shoulder down my arm, most especially.
Good question, because it seems like it's very common to have shoulder and neck injuries at the same time. So moving now to instability of the shoulder, shoulder dislocations and labrum tears. So what causes shoulders to dislocate? The shoulder is a very mobile joint. It's inherently unstable, and through the muscles and ligaments, they provide the stability of the joint. We often think of the shoulder as like a golf ball on a tee. So the saw bones on the left there shows the ball and socket of the humerus and the glenoid, and then obviously on the right is the ball or the golf ball and the tee, and really that you can just see how that is just not very stable, and that's why we see more shoulder dislocations than maybe elbows or ankles or knees. So what are some intrinsic things that prevent the shoulder from dislocating? Well, it's really the depth of the labrum or the depth of the socket. So the deeper the socket, the more stability that you'll have. And so any injury to the labrum then will cause more instability. So that's the structural cause of some of the instability. So once again, getting back to the golf ball and the tee, the golf ball on the left, you can see somewhat unstable. The golf ball on the right, as you deepen or widen that socket, that will cause more stability in the shoulder joint or in the golf ball in this instance. So once again, prevention, that's what we're talking about today. How do I prevent this instability in my shoulder, or how do I prevent it from dislocating once this has occurred? And it's really, we've been hitting range of motion hard for most of this talk, but this is an issue with too much range of motion. So we want to really talk about stabilization and strengthening of the shoulder, and then activity modification. So this is where Chris comes in.
So something that we haven't discussed to this point is, what about the shoulder blade and posture and stability? One thing that you can do to really benefit your shoulder joints and help prevent injury is to work on your posture, and that means improving your extension, your upright sitting position, your axial extension. And you can do this simply by performing some scapular squeezes, which is the top exercise where you just simply retract your shoulder blades and hold them in an isometric contraction for a few seconds and then relax, and do that repetitively. Or to increase the difficulty slightly, you can do it on your stomach with a shoulder blade squeeze and slight arm lift. And then to further advance that, you could simply hold some small weights in your hands. Some other exercises would be moving the arms in other positions, other angles that promote recruitment of specific muscles that go from your trunk to your scapula, which is your scapulothoracic muscles. And this will help improve your strength and the position of your scapula and your scapular coordination. You should know that when you reach overhead, it really is a complex interaction of your scapula and your humerus and your clavicle. And it involves what we call force couples, which is opposing muscles working in a coordinated fashion to produce movement of a bone about an axis. So when you raise your arm overhead, your shoulder blade has to rotate upwardly and somewhat forward. And this is produced by the trapezius and the serratus anterior. And the exercises on the right demonstrate some appropriate exercises for working on those muscle groups. So how do we progress? So as the rehab process advances, you will be given more challenging exercises. You would gradually increase the resistance and difficulty. And this is if you're doing it on your own as preventative. Typically, we start with what we would call cardinal plane exercises, which is the basic straightforward arm raise or the sideways arm raise or internal versus external rotation. What we would do to advance is the exercise on the top left, which is a diagonal, or what we call a PNF type exercise, where it incorporates multiple planes of motion simultaneously. We would also advance to weight-bearing exercises like push-ups, and then advance to functional movements, which would include reaching and lifting. And then we would begin to try and start adding exercises exercises to get you back towards your activities. We would, towards the end, add things like plyometrics. You can see the individual on the top left pressing up on the boxes and then coming down between the boxes and being able to load and accept the load in a dynamic fashion, which is much more challenging. And then a sideline catch and release with the ball, or the rotation that's performed with the shoulder in a more abducted position, which would simulate more of a throwing type motion. The Throwers 10 is a group of exercises that was developed some years ago by Kevin Wilk and Dr. Andrews. And it's a group of 10 exercises that were developed for throwing athletes. And it's something that you can easily find online. I believe it's open source. You can print it out and try those. And honestly, a lot of the exercises that we have illustrated for you today are on that sheet, but that would give you a nice handout to work from. And then, of course, you know, your ultimate thing would be to return to your sport or your occupation, or even just being able to play catch with your kid in the backyard. We would endeavor to simulate your activities of living as closely as possible. And then ultimately you would be on your own and continue on with your home program.
So what happens when the labrum is torn? And this is an arthroscopic picture, an arthroscopic view of the right shoulder, where the labrum, and think of the labrum, it's very similar to the meniscus in your knee, but we call it the labrum in the shoulder. It's a washer that really, as we talked about, deepens that socket to provide stabilization. And the labrum here is torn around, and we think of the glenoid as a clock. So this is kind of your typical tearing of the labrum, maybe from a 10 o'clock, which is in the back or posteriorly to approximately the 3 o'clock, which would be in the front or anterior portion. And what we will do arthroscopically is, once again, place anchors in the bone and then tie the labrum back down to the bone, the glenoid, and this provides a deeper socket, therefore providing more stability within the shoulder joint itself.
Okay, and I think we have some instability questions. And the first, is it typical for a shoulder injury to seem to have resolved and then flare up again? I don't know if I'd say it would be typical, but it can happen. And there's various reasons for that. In the example of if it possibly coming from a issue with your neck, that could seem like an injury that tends to get better and then flare up again, almost seemingly on its own. And you may have difficulty linking the two together. If you don't fully rehabilitate your shoulder, either post-injury or post-surgery, it could feel better and then start to bother you again if you are not quite as consistent with your home exercise program. That can certainly happen. Or if you just, you know, are feeling better and then go back to activity and then get into a overuse situation, your symptoms could flare up again. That could certainly happen.
So will I be able to return to throwing or contact sports after surgery? Certainly that's the goal. Our goal is for you to return to 100% of the activities that you would like to participate in. Now, remember, when we're talking about it specifically, talking about a throwing athlete and returning back to sport, the goal is to get that athlete back to the level which they were at previously. So if it's a high school pitcher, the goal is to get them back to high school pitching. If it's a major league pitcher, the goal is to get them back to major league pitching. If it's a college football player, it's to get them back to college football. So, and specifically in instability, if it's a contact sport or a collision sport like football, oftentimes returning with some sort of brace will be required. Remember, we don't make you better than you were. We just kind of put everything kind of back together. So that is certainly the goal, is to get you back doing 100% of the things that you want to do.
Okay, so the next question is, what can I do to prevent injuries to my son, let's say your son or daughter's shoulder? Well, some of the things that we've already discussed would be appropriate. I think ensuring appropriate strength and stability, making sure they have appropriate flexibility. But the other thing would be activity modification, or, you don't want to say limitation necessarily, but knowing when they may be getting to a position of overuse, maybe participating in too many activities simultaneously can cause an overuse syndrome. So monitoring that would be important. And, obviously, whatever you can do to start them on a path of really being proactive about keeping their shoulders, say they're a Little League pitcher, happy and healthy by doing appropriate exercises and, appropriate cool down and stretching, maybe some icing, those kind of things can all play a role.
And just kind of to piggyback on that, when we speak to the local little leagues, we like to think about a kind of a progressive program. So Chris talked about the throwers 10, but I think it's important to get the kids doing something very minimal, even at the T-ball level. So you start them on a small program. It may be 1 or 2 exercises or stretches, but then each year you're adding on to that program. So by the time they're in AAA, or they go to Pony, or they're in high school, that they now are very used to every day doing my shoulder exercises, and it slowly builds up. But that throwers 10 is a good place to, if you're looking for some place to start. Can you speak to what might be causing clicking or catching in the shoulder joint? The chasing, clicking, and catching is very difficult, especially in the shoulder joint, because there's so many things that can click, and it's almost natural that something is clicking or rubbing. Certainly, it can be any of the conditions that we spoke of before: labral tears, rotator cuff tears, instabilities, AC joint arthritis. But it's very difficult to chase clicking down to one thing. And the human body is about 60+% water, so you're going to hear the clicking more than me. And even sometimes trying to feel the exact location of the clicking is difficult, just because of the muscles that are around the shoulder often fool you on where the actual clicking is coming from.
And if I might, I might piggyback on that question a little bit. In my experience, the clicking and catching of joints, as Dr. Peterson said, is not really all that uncommon. The one thing that I don't share with my patients is that I'm going to promise that I'm going to get rid of the popping and clicking in the joint. Knees click and pop when you go up and down the stairs. I guess the important thing is it associated with a pain or a locking, such as like a knee where you just can't bend it any farther? That's a whole different story. But, as Dr. Peterson said, trying to just make that as your central goal is probably not worthwhile. So I think that is the most of our presentation. We have some thank yous.
So I would like to thank Dr. Jason Hsu. He provided me a number of these slides as well as intraoperative photos. So I'd like to thank him for that. And then the next slide is going to be our contact information for any type of appointments that you may have. So I'm at the Sports Medicine Clinic with the 206-668-6100. And Chris, you're at
206-668-6828.
For appointments.
Yeah. Okay.
Yeah.
I think that concludes our presentation.
Great, thank you so much. Thank you for this presentation. Thanks for all of our attendees who joined behind the screens. We can't see them. We will be posting a recording of this webinar to YouTube, and we'll send out a link, like I said earlier, to that video by email in the next couple of days. So you can review it again or share it with folks who you think might be interested. And you can always learn more about our providers and our clinics at uwmedicine/ortho. So thanks so much. Oh,
Thank you.
Oh,
well, see, we have one more question in the chat, but I'm not sure if we can get to it today.
Let me-
Thanks so much.
Let me see.
everybody.
Let me read it real quick. 14-year-old has been playing tennis for around 5 to 6 years. She has a shoulder injury, which the doc said was similar to little league shoulder. She's been prescribed rest and then PT. Would a chiropractor help with the injury, or is it only PT? So difficult to tell exactly what the physician is talking about, but normally at 14-year-old, it's going to be probably an injury to the growth plate around the shoulder is what I'm thinking he's talking about. And the rest is it should be active rest, you know, and this is where physical therapy would be great for your daughter, because you really need to strengthen up that scapula, you know, to allow your daughter to play as much tennis as she is looking to play, but also range of motion. Whichever physical therapist she ends up with, really remember range of motion, internal rotation, scapular strengthening is really what I would recommend as far as a chiropractor to help with this injury. I have nothing against chiropractic medicine, but I think it's going to be a strengthening and range of motion issue.
Great. Thank you so much, Dr. Peterson, for that last answer for us. Again, thank you, everybody.
Thank you.